let's go through the first lectures of from Tuesday. Okay, guys. So if we remember from Tuesday, we talked about three things. We talked about kind of the birth of medical terminology, right? Roots, right? Where it comes from, all those types of things. And we also, did a lecture over anatomical terms, and we did a lecture over dermatology as well. So my first question for you guys, who can tell me, as far as roots for medical terminology generally come from, which languages what languages do our roots come from that term? Usually. All right, Danielle, Latin and Greek is correct. And Mary, yup. Addie, thanks, guys. All right, so, okay, name one of the four methods used in constructing medical terms. Abbreviation, yep, Bryce, nice job. Okay, what's another one? What? Whoa, it's moving fast down there in the chat. I can barely keep up. All right, derivation I saw, or actually deviation. Okay, so derivation, yeah. And then MSS abbreviation. Okay, good. Okay, all right. Here, okay, cool. Next thing. So, okay, guys, so one thing that we kind of talked about, kind of towards the end of that first lecture, as he says, compounding, thank you. So what is our job? So all of us are clinicians, or we're going to be clinicians someday, potentially, and taking care of people, right? So what is the function of using medical terminology in everyday life, in clinical practice? What does it help us do? And this is actually more of an open-ended, like, tell me what you think question, not necessarily like a right or wrong question. Feel free to unmute yourself and talk if you would like to. The cat's blowing up. I heard a voice.
Yeah, that's me. For me, I feel like it's so that everybody can be on the same page.
Okay.
If you're using a well-defined set of terms.
Okay. I like what you said. You said so that everyone can be on the same page. Okay. Why is that important, particularly if you're a clinician and you're providing healthcare and taking care of people? So go ahead. Sorry.
Because you might have to recommend them to like a specialist, and if you have to do that, you want to make sure that they're getting exactly what you think.
Okay, yeah, and so ultimately we want to make sure that the language is clear so that they understand their diagnosis, first of all, right? And that they know what the plan is moving forward, right? We want to try to make sure that things are as simple as possible, because remember, and towards the end of the lecture, we talked about how people tend to actually perceive medical terminology as something that lends itself to kind of a higher level of seriousness, maybe more urgent referral, right? But they may see that and think, oh my gosh, I'm going to die and I need to be seen right now. When in reality, they just have an ingrown toenail or what have you, And so if we use plain language when speaking with people, generally it helps to kind of quell some of that anxiety. Okay, cool. I'm glad we're kind of moving on the right track. Okay, the next thing, let's do some review of anatomical terms. Okay, I tried to do this sitting down during the first section, and it didn't really work that well. So I'm going to go ahead and stand up, and we're going to do some review of anatomical terms and directions. Okay. Okay. So, can you guys? No. Henry. What about that? Better? No. Okay. Apparently my microphone is shaky or something. That's what I was told this morning. Wasn't really that exact word that was used, but about now. Better, like the same, or like we can actually hear you? Okay, great, wonderful. That helps. Okay. All right, here we go. So I have a front half and I have a back half, obviously, right? If I'm talking about the front half of my body, okay, which direction am I talking about? What term would we use? Anterior, wonderful, crushed it. Okay, back half. What side? Posterior, Bingo. Cool. All right. Cool. Anatomical terms. I have an anatomical position this way. Okay. My thumb is what to my pinky? My thumb is what to my pinky? Lateral. Got him. Awesome. Okay. Now check it out. Okay. My shoulder. Now I'm on an extremity. My shoulder is what to my elbow? Gets a little tricky. Proximal. Yes, absolutely. Nice job. Okay. Okay. Now pertaining to the trunk and neck. So we're up here now. Okay. My head is what to my chest? Superior. Got it. You guys are crushing it. That's amazing. Okay. Good stuff. Good stuff. I'm so sorry. Oh. Horrible. All right. Okay. Cool. Let's talk about the skin. Let's actually get into review of dermatology. Okay, the skin has two main layers, right? Who remembers what they're called? Whoop. Got it. Good job. You guys are fans of the chat. Use it a lot. Okay. Okay. Wow. Nice. Okay. Okay. So dermis and epidermis. Who can tell me what type of cell makes up 80% of the epidermis? Very nice, Amelia. Yep. Amelia, were you the one that wanted to be a dermatologist? I think I remember that from your intro. Dude, yeah, go you. Nice job. Okay, good. All right. What cell makes up 20% of the epidermis, friends? Melanocytes. Very good, Egan. Nice job. Okay, cool, cool. All right. Okay, let's go. Let's roll through some terms from dermatology and see what we remember. Okay, who can tell me? Okay, what is the meaning of the root word unguo? Nail. Got him. Good job. Nice, Izzy. Okay. All right. This is a tough one. Dermo. Yeah. Nice. Dermato. Yes and yes. Skin. Okay. Cool. Cool. Awesome, guys. Sounds great. Okay. Let's go ahead then, and we're going to jump in face first to our stuff for today. Okay. Oh yeah. And actually, yeah. No, I think we covered everything as far as review from last time. So let's get right down to it. I just thought of a joke, but it's probably not very funny. It's completely and totally appropriate. But what do you call an offensive lineman with asthma? No offense to people with asthma. What do you call an offensive lineman with asthma? Big wheezy. Anyway, that's enough. Okay, moving on. I thought it was pretty great. I tell that joke a lot. I think it's a classic, but other people seem to think otherwise. So, all right, friends, here we go. The cardiovascular system. Okay, so clearly, let me share my screen. Zoom. Yay, fun. Here we go. The cardiovascular system. Okay, obviously this consists of the heart and vessels. Okay, just to be clear, this class is not an anatomy and physiology class, but in order to introduce the terms to you, we have to at least go through a very brief explanation and kind of flyover, if you will, of the anatomy, right, to be able to introduce terms. So, really and truly, and I told the first class this morning, you will not be like heavily tested on anatomy. Like that's not the point, right? The point of this class is for you to learn terms, root words, learn how to communicate. But back to this. Okay, so obviously the cardiovascular system is made up of the heart and blood vessels. So the main function of the cardiovascular system, obviously, is delivery of nutrients and transportation of waste products, right? And also maintenance of tissue perfusion. So who can tell me, what do we think in tissue perfusion obviously means delivery of blood and oxygen to tissues. So blood contains oxygen, we need to get that to tissues in order to live. Here's kind of a critical thinking question to kind of think about perfusion. Why do you think that someone who is in cardiac arrest would potentially have permanent neurological deficits after a cardiac event? So sorry. Why do you think that would be the case? Particularly thinking about perfusion. Oh my gosh. Computer.
They're not getting oxygen to their brain.
Brain, absolutely. So there's a lack of perfusion, a lack of oxygen to the brain, which can result in a neurological deficit. Okay. Cool. All right. Obviously, too, through the pulmonary circuit, the heart also delivers blood to the lungs, where it gets reoxygenated as it passes through the alveoli, and then out back into systemic circulation. Okay, let's go over just a little bit of anatomy here, guys. Okay. Excuse me. So the heart consists of 2 top chambers and 2 bottom chambers. Okay, the left and right atria, it's plural for atria. Okay, so the left atrium and the right atrium. Obviously, the bottom chambers are the left and right ventricles. The right ventricle contracts and essentially pushes blood into the pulmonary circulation, whereas the left ventricle actually pushes blood into the systemic circulation. You'll notice if you look at the ventricle in this picture, and the difference is not all that perceptible in this picture, but you can definitely tell that the left ventricle is actually slightly thicker. The reason for that is that there is more contractile force required at the left ventricle for blood to be pushed out of the heart and into systemic circulation. One pathology that we see generally in athletes, particularly endurance athletes, is that over time there can be a pathologic, which means abnormal, pathologic thickening of the left ventricle due to the amount, of aerobic exercise that they do, right? And that is known as hypertrophic cardiomyopathy. And what can happen there is that as the ventricles continue to thicken, right, because they are a muscle, right, as they continue to thicken and hypertrophy, the amount of blood that can fill that chamber actually goes down. So it lessens the stroke volume, which is the amount of blood pushed out of the heart with each contraction, as the ventricle tends to thicken. Okay. Obviously, going through valves, on the right here, we have the tricuspid valve that separates the atrium from the ventricle. On the left, that is the mitral valve, also called the bicuspid valve. Sorry, guys, I'm going to take a Mucinex real fast so I don't continue to cough throughout this entire class. Okay. Also, if you look, all right, at the these little muscles down here, we have the papillary muscle and the Cordy tendineae. Okay, you can see that the Cordy tendineae are actually attached here to the valves themselves. All right, and when the papillary muscle actually shortens, and that actually happens during the portion of the cardiac cycle, the valve opens and the muscle actually pulls on the Cordy tendineae and pulls the valve open. Okay, so we have that papillary muscle that actually contracts and actually helps us and pulls on the Cordy tendineae to actually hold the valves open for us. Okay, so another thing, guys. Also, you'll notice here on the right, we have the interventricular septum. So this is actually the wall that divides the left and right atrium and left and right ventricles. There is a condition often that you'll find in infants called a patent foraminal valley. Okay, and the patent foraminal valley is actually where the septum, the wall between the left and right atrium, actually does not fully close during the fetal development process. And ultimately, right, if untreated, this can actually lead to things like cryptogenic stroke. We do see actually that the way that this is diagnosed, it's actually pretty cool. They go in and they actually inject saline into the atrium, and if they see a flow of saline from the atrium into the ventricle on ultrasound, they can actually diagnose a patent foraminal valley that way. Those often they close on their own, but there are times where those actually need surgical closure. Okay, all right, guys. So we obviously talked about the heart's role. Excuse me. We talked about the heart's role in perfusion, right? Sending blood into the tissues, right? But the one thing that we also need to discuss is how the heart muscle itself actually gets its nourishment, right? So that it can continue to function. And that actually happens through the coronary artery and venous system. Okay, so we see over here, right? We actually have the obviously the aorta and superior and inferior vena cava, but branching off of the aorta, right? Particularly here on the left, okay, we have the circumflex artery and the left anterior descending artery coming off of that. Now, the left anterior descending artery actually is the artery that's actually most often implicated in myocardial infarction. Can anyone take so quick quiz question here? What's the lay term for myocardial infarction? What's the normal people term for myocardial infarction? Check. Heart attack. Yes, yes, yes. Nice job. Okay, cool, cool. All right. So obviously, coming back, right, back to the aorta here, we have obviously the aortic arch, but then coming off of the aortic arch, right, we have the brachiocephalic trunk, right? And then we have the left common carotid artery and the left subclavian artery. So off of the brachiocephalic trunk, though, that actually branches off superiorly and becomes the right common carotid artery as well. Now, for those of you that have had me for some athletic training classes, we've talked about the subclavian artery and the importance of that, particularly in dealing with people that have AC joint or SC joint injuries. In the event that there's an injury to that joint and the clavicle actually falls posteriorly, that is obviously a medical emergency because we can have vascular complications to the upper extremity. Okay. All right. Okay, friends. Okay, the conduction system of the heart. So we know, and I know that you guys have had a lot of this material already in anatomy and physiology, but obviously, if we remember, right, there are two nodes that regulate heart function. We have the sinoatrial node, or the SA node, and that is the node that actually initiates the heart rhythm, right? Conversely, though, we have the atrioventricular node, or the AV node, excuse me, that actually regulates the heart rate. So the SA node initiates the rhythm, it travels down to the AV node, and then from the AV node, it actually travels down the right and left branch bundles to the myocardium. And that's the anatomy of how the heart beats. Okay. All right. So guys, getting into arteries and veins. I know, by the way, if you guys don't have this book and you like anatomy and physiology, I highly recommend it. I know it seems kind of childish, but this book is called the Anatomy Coloring Book. It is the bomb. It's super, super great. Okay. You can actually go through and learn actually pretty high level anatomy, at least in regards to detail. And it actually lets you color a lot of the stuff, which if that's your it's pretty cool. So highly recommend it if that's something that you're interested in. So we're talking about obviously arteries and arterioles, okay, in the venous system. So with the arteries, obviously we have the arteries coming off of the aorta, right? And as they decrease in diameter throughout the extremities and throughout the trunk, they eventually branch off into small arterioles and then into capillary beds. When the arteriole branches off into the capillary bed, it then coincides with the venous system, right? And this is actually where gas exchange occurs at the site, right? And then obviously It returns into circulation via the venule, back into the venous system, and then into the superior and inferior vena cava, and then back into the heart. Okay, so now, obviously, okay, the difference though between arteries and veins is that there are definitely layers, right? There's essentially the tunica interna, which is the innermost layer of the vessel, tunica media, right? And the tunica externa. So, quiz question for you guys. Who can tell me the main difference between an artery and a vein? And I'll put the question this way. What do veins have that arteries don't have? What do veins have that arteries don't have? Negative. Okay. All right. No guesses? Okay. Well, yeah, Kool-Aid. She got it. Yep, valves. Got him. And actually, I saw heart attack above that. Yeah, sorry, that was actually you responding to the last question. But yes, valves, absolutely. Yeah, veins have valves, right? So when we think about the venous system, particularly the lymphatic system, right, we remember that we have a muscle pump, right? We have a muscle pump that actually helps us push like deoxygenated blood and even lymph fluid from the extremities back up towards the heart, right? To be put back into circulation, so that it can be reoxygenated, and for lymph material, so that it can be essentially deposited into the thoracic duct, so that it can be disposed of properly. Okay. All right. So yeah, valves. Anytime we move, anytime we breathe, we are activating the muscle pump and pushing the deoxygenated blood back up the vein and back into circulation. Nice job, Khalid. All right. Root words. Here we go. This is the reason why we're actually here. All right. Root words. Or as my friends up here say, rut words. Oh, here we go. Sorry, that was not meant to be offensive, but I just kind of funny. Root words. All right. Cardio. And so if you guys haven't figured it out, I think laughter is a good thing, and I try to make that happen in my classes. Some of you don't look very amused right now. So, but I think laughter is fun, and I try to do that often. So cardio or corono, right? That is the root word for heart, right? So ultimately, if you see cardio or you see corono, right, that is pertaining to the heart. Now, here's a question for you. Based on what we just learned, okay, when looking at the anatomy of the heart, looking at the anatomy of the heart, corono, generally speaking, is that going to pertain to the outer wall of the heart, to basically the external surface of the heart, under the pericardium, or the inside of the heart? Who can tell me? Guess I'll just wait on the chat. All right, two of them. Look at that. Okay. Okay, Kool-Aid. All right, it says inside. Okay, actually remember. So here's a way to remember that. Where does the coronary artery live? Does it live on the inside of the heart where the valves are, or is it on the outside of the heart? And Mary says outside. Yes, Mary, yes, correct. Outside. Okay, nice job. Okay, and those are actually branches off of the aorta, believe it or not. There's the foci where those branches come off. Okay, here we go. Angio, okay, that is the anatomical root for blood vessel. Okay, blood vessel. Aorta, right? Valvo or valvulo means valve, right? Ventriculo, ventricle, and flebo or flebo. You will hear it pronounced both ways. Vein. Okay. By the way, sorry if you guys can hear that in the background. It's my dog. He literally sits next to me and whines the entire time while I'm teaching, and it's ridiculously distracting. I will show him to you really quickly. I can see there we go. Yeah, he literally does this the entire time I'm on Zoom. Like, he just whines, and it's really hard to focus. But
Whoa. Can you guys, just out of curiosity, can you hear me better now? Awkward. That's weird. So ultimately, speak connection, but apparently you can hear me better than you could before. Yeah. Okay. All right. Well, okay. Let's talk about some prefixes though. Okay. We talked about endo. That's inside of the heart. So we have these three layers of the heart. Okay. Remember, so you go back to anatomy and physiology. I'm going to draw a little picture here. It's going to be poorly drawn, but I'm going to do my best. Okay. So this is, we're just going to call this a wall of the heart. Okay. That's the outermost layer. Okay. It's the layer surrounding the heart. That's the pericardium. Okay. Then I have the heart muscle itself. So then I have I'm going to draw these little lines. Okay. Signifying the heart muscle. Okay. That is the heart muscle. That's the myocardium. All right. And then on the inside of that, I'm going to draw another line. Okay. That's the endocardium. So pericardium, the covering around the heart. The myocardium, which is the heart muscle itself. Excuse me. And then we have the endocardium, okay, which is the inner covering of the heart. Okay. Clear. How can I get rid of that? Come on. Sorry, guys. Zoom issues. There we go. All right. Sorry about that. Cool. Okay. Let's talk about some pathologies that we commonly see, right, in the cardiovascular system. Okay. Root words. Okay. Thrombo. Okay. Thrombo. That is a root word for clot. Okay. Issue. And honestly, you don't really see this root word used that much anymore, particularly in modern day. But issue is a root word for a deficiency or blockage. Sorry. Okay. Athero. Okay, this is fatty plaque. Okay, fatty plaque. Brady means slow. Okay, so here's a question. If someone is bradycardic, if they're bradycardic, what do we think that means? What does bradycardic mean? Oh, man. Okay, very good. Slow heart rate. Generally under 60 beats a minute, right, is considered bradycardic. What about tachycardic? Okay, we know what brady means, so it makes sense. What does tachy mean? Tachycardic. Yep, absolutely. Okay, they have a fast heart rate, over 100. Okay, all right. So here's the deal. Here's another question though too. All right. So we know that thrombo is the root word for clot. Okay. Bless you, Justine. Just saw you sneeze. All right. So here's the deal. Here's my question for all of you, for the entire class. What is the best way? And I'm asking this because all of you, the vast majority of you, except for maybe a couple, are going to be clinicians someday, taking care of patients, right? What is the best way to prevent blood clots? Who knows? What is it? Looking at the chat. Nope, nothing. Okay. What about, oh, never mind. JK, there it is. Yes, Mary, exercise, also known as vigorous movement and or movement in general, right? That's the best way to prevent blood clots. Yes, Egan, baby aspirin, freaking crushed it. Nice job, sir. Okay, here's the deal. Here's why I asked the question. Okay, a lot of you guys, particularly if you end up in your career, if you end up in like, maybe you're going to be a nurse, maybe you're, working in a post-op clinic, right? Or maybe you're seeing someone and they're a week out from a knee replacement, right? It's not uncommon at all for them to be on 1 or 2 baby aspirin every single day, right? For general arthroscopic procedures, that's generally about a week. But for a knee or a hip replacement, that can be up to 6 weeks, okay, or more, right? Not at all uncommon. Why would that be the case? If you think about how long these individuals are immobilized for, right, how long they're down for, there's definitely an increased risk for development of blood clots. Okay, so that's definitely, you guys are absolutely correct. Yeah, Mary, nice. Egan, very good. I'm proud of you guys. Nice job. Okay, so, and I have one story actually relating to blood clots. I actually got stranded in a foreign country one time with so years ago, I took a trip with a men's basketball program to Costa Rica. And we're on the plane, literally on the plane, over the middle of like the Gulf of Mexico. And I'm sitting in my seat, and our men's basketball coach was sitting kind of beside me, but behind me. All of a sudden, he puts his right leg up on my armrest, and he goes, "Does this look swollen to you?" And yes, his leg was swollen. Okay. Unbeknownst to me, he had an appointment with his cardiologist earlier in the day who told him not to travel because of his atrial fibrillation. Did he tell me? Absolutely not. Did he get on a plane? You bet he did, because that was smart, right? So he gets on a plane. So we land in San Juan, Costa Rica, and we're literally going around asking people where we can find aspirin and or anticoagulants in Spanish, if you can imagine that. So I'm in a foreign country, and we're trying to keep this man from like dying, but and trying to find him anyway. So funny story there, but anyway, yeah, we'll move on. Sorry, y'all. So let's talk about some pathology-based suffixes. Okay, AC. Okay, pertaining to apheresis, removal of. Okay, crit. Okay, so hematocrit. Let's actually kind of give you a word there that kind of goes with that suffix. Hematocrit. So when we take blood and we put it in a tube, and we put it in a centrifuge and we spin it out, right? We're able to separate the plasma from the red blood cells in that blood, and the result, and a lot of times we'll get a lab value based on that test called the hematocrit level, right? Which is the concentration of red blood cells within that sample. Okay, so graph, recording, odynia, okay, is the root word for pain. Okay, we're going to see this term again, actually, when we talk about musculoskeletal pain towards the end of the class. We use a term called coccydynia. Coccydynia refers to pain of the coccyx, which is a little tiny bone that sits right underneath the sacrum in the lumbar spine, right? So fun fact, right? Pnea, okay, few or abnormally low. Okay, if someone is cytopenic, excuse me, what do we think that means if they're cytopenic? Any ideas? Someone's cytopenic, what do we think that means? Okay. Yeah, Mary, low cell count, very good. They have a low cell count, okay? Few and or abnormally low. Sorry, guys. Ugh. All right. Whoa. All right. And then stenosis, okay, that means narrowing. So if somebody has stenosis, okay, particularly, and this can happen in many places within the cardiovascular system. Okay, how do arteries, how do they become narrow, generally speaking? If someone has, maybe they have stenosis of an artery. What's that generally due to? Okay, Danielle, pour out the stress. Okay, nice answer. Okay, remember we talked about plaque. Okay, plaque can actually cause that stenosis or that narrowing of the artery. Okay. We can also have narrowing of a heart valve. Okay. We can have mitral valve stenosis. Okay. Or we can have, mitral valve stenosis and or even stenosis of the tricuspid valve and or the pulmonary semilunar valves as well, the semilunar valves as well. That can happen. Do you think that that would increase or would the amount of blood coming out of the heart in that situation decrease or increase? In the event of stenosis of a valve, the amount of blood ejected.
Decreased.
Yes. Okay. First of all, my first verbal response of the afternoon, was that Egan? Actually, Leah. Who was that?
Yeah, it was me.
Oh, sorry, Justine. Sorry. Yeah. And the reason why I said that, guys, is I like seeing you guys actually talking, and it makes things more engaging. And that's obviously my preferred method of interacting with you guys. I know Zoom has a chat function, but talking is really what I'm going for. Okay. So, okay, stenosis. Nice job. All right. Cool. All right, friends, here we go. More terms to know. Okay, terms to know. Anemia. What do we think anemia means? Who can tell me what that is? Okay, lack of iron. All right. So there are many different ways that can happen. One of the most common ways actually is after hemorrhaging or trauma. We can actually see what's called acute blood loss anemia due to blood loss. So iron, the iron content in the blood falls simply because the volume has been depleted, and so that proportionally the amount of iron available is less. Right. Okay. What about angina pectoris? What do we think that means? Angina is typically what? Yeah, chest pain, Kool-Aid, excellent. Okay, Mary, up. Okay, cool. All right, guys. Okay, here's a question that I asked the class this morning. We had actually, it was a really fun conversation, believe it or not. We need to talk about the difference, okay, between a deep vein thrombosis or a DVT, okay, and an embolus. Okay, who can tell me, and we'll just see if anybody knows, what's the difference between a thrombus, okay, or an embolus? What's the difference between those two things? We'll give it a couple more seconds. Okay, here we go, guys. So the reason why I'm bringing this up, right? Like I said, want to try to make this class as applicable as possible. Okay, and clearly, yeah, I mean, going beyond kind of the memorization of words. Okay, DVT, deep vein thrombosis. Okay, a thrombus is a stationary clot. Okay, it's staying in one spot. All right, generally speaking, these occur in the deep venous system, generally of the leg. Okay, you can definitely get these in the upper extremity, but it is a lot more uncommon, a lot more rare, right? But we see them a lot more often in the lower extremity. So here's a question. If we know that a clot or a thrombus is sitting inside of a vein, stationary, is that going to decrease the venous return or increase the venous return? Will it go up or down? What are we thinking? Yes, Danielle. Hashtag crushed it. Nice job. It'll decrease. Yes, because, okay, think about it. Okay, it will go down because look, if you have a clot sitting inside of a vein, Okay. What is happening there is an obstruction to venous return back towards the heart. As a result, the venous return is lower, right? Because not enough blood is returning to the heart because of the clot. Now, as a result, let's say that we have a clot. I'm going to draw a picture, guys, again. I'm going to draw a picture. Here we go. Here's a leg. This is a really badly drawn leg, but it'll have to do. Okay. So my thrombus, I got a vein. This is my leg. Okay. There's my vein. Okay. Okay. Boom. Here's my thrombus hanging out right there inside of that vein. Now, Danielle said that venous return is going to be lower, and she's absolutely right. Now, what's likely to happen, though, distal to this clot? Because fluid and blood can't get back to the heart, what am I going to see down here? Who can tell me? Heck to the yes. Swelling and inflammation, Mary. Yes, we're going to be crazy swollen down here. We're going to see edema formation. Yes, absolutely right. Okay, so all that to say is that there's a certain subset of swelling after surgery that's normal. Okay, however, all right, in the event that it is excessive and it is actually affecting pulses in the foot, okay, then we know we have a problem and might need to send the patient for a Doppler ultrasound to make sure they don't have a DVT. Okay, but look what happens if, I'm going to clear my drawing, what if this clot says, peace out, and it breaks away and actually enters the free circulation? What happens? Then a clot that is no longer stationary but is mobile becomes an embolus. Okay? A clot that is no longer stationary but then becomes mobile becomes an embolus. Why is that a problem? That's a huge problem, by the way. Okay? Because what if that clot moves and lodges actually in the lungs? Okay, then we have this pathology known as a pulmonary embolism that can kill someone. Okay, or what if that embolus actually goes and lodges in the brain? It can cause a stroke. Okay, so that's the difference, right? And for all of you that are going to be working at some point in your lives, in maybe some sort of post-operative setting, whether it's rehab or you're going to be a nurse, right? Probably even, I said shoot, even exercise physiologists, you guys are going to, potentially see some of this too, right? Potentially doing cardiac rehab, right? You will see, you're going to see these DVTs. It's going to happen, right? And knowing how to potentially pick these up, it's going to save someone's life. Okay, cool. This is fun. It's fun for me. I don't know if it's fun for you guys, but time will tell. Okay. All right, guys. How do we code cardiac diagnoses? Okay. As promised, we're gonna work a little bit of ICD-10 coding into this. So if you look at your little laminated chart, there's mine. Or you can use the link I posted on Moodle. Right here it is. ICD-10. It's a wonderful thing, but not really. Okay. You're going to find those and note that's the letter I, not the number 1, I00 through I99. Okay, that is the code section where you're going to find a lot of these diagnoses. Okay, now, also not uncommon, excuse me, also not uncommon, that we'll need to also attach other diagnoses codes from the hematological system, the blood, right, in dealing with some of these cardiac issues. Okay, and those are going to be found in code groups D50 to D89. Okay, what's an example of that? For example, in a patient with atrial fibrillation, okay, one of the biggest risks with AFib is actually blood clots. Okay, you can actually, because the blood is quivering inside of the top chamber and not actually, reaching the ventricles efficiently, you can develop clots. Now, in the event that someone also experienced a blood clot as a result of atrial fibrillation, we would then code for that diagnosis, and that would be secondary to AFib in the diagnosis code. And you guys will see that when I post the example tomorrow of the diagnosis and coding assignment. Okay, so you'll see actually what that looks like. All right. Okay, cardiac. There it is. Okay. Let's move on to respiratory. Any questions about any of this before we go to the next one? Any thoughts, questions, concerns? You guys are, yeah. Okay. You guys doing okay? I feel like J-term is like, just like crushing people's dreams. That's really kind of what it seems like. I see some head nods. I get a yes. Okay. Well, I'm sorry that's happening. Maybe this class won't be as much for Dream Crusher for people, I hope. All right, friends. Okay, respiratory. Here we go. Okay. Get that pulled up. All right. Okay, sweet. The respiratory system, guys. Okay, here's the deal. Okay, maybe other than would you stop? Maybe other that's my dog is driving me crazy. I'm sorry, y'all. Other than the musculoskeletal system, the respiratory system is going to have probably the most terms that you guys are going to see. What is wrong with you? He's like gagging. Sorry, that's gross, but sorry. Okay. Okay, friends, check it out. So the respiratory system, okay, encompasses everything from the nose all the way down to the lungs. Okay, and we can even see down here in this picture, the diaphragm. It's the diaphragm, okay, but it's fun to say diaphragm. All right, the diaphragm. Okay, here's the deal. So air enters the respiratory tract through the nose, where it is warmed and moistened. Yay. Okay. And then hits the back of the nasopharynx at the top, travels into the throat, and then down into the larynx. Okay. And into the trachea. All right. It then travels through the trachea into the lungs, where gas exchange occurs at the level of the alveoli. Okay. So that's the respiratory system in a nutshell. But let's take a look at some things. Let's kind of break it down. Okay. Okay. At the very top of the trachea actually lives the vocal folds, okay, the larynx, the vocal folds. Now, we've actually identified some anatomy here, okay? So you can see the arrows here pointing to the vocal folds, okay, right at the top. These two little kind of lines, right in the middle of the empty space is the glottis, okay? And then right behind that is the epiglottis, okay, right there. Epiglottis, right directly posterior and slightly superior to the glottis itself. Excuse me. So we have the vocal folds, okay, and then we have cartilage. So at the front, okay, the cartilage that's the most anterior here is the corniculate cartilage. Sorry, here, and then just lateral to that is actually the cuneiform cartilage. Okay, so there's actually a common condition that we see, and you guys have probably heard of this. Maybe you have dealt with this yourself, right? Called vocal cord dysfunction. Okay, it can very much mimic exercise-induced asthma. Okay, the only difference is what this is that this is actually excuse me, this is actually paradoxical movement of the vocal folds during inhalation and exhalation that actually causes throat tightness, difficulty breathing, and even wheezing. Okay, very often it's confused for asthma. Okay, but this can be actually diagnosed via pulmonary function testing. All right, so pulmonary function testing can tell us whether or not someone actually has vocal cord dysfunction, whether they have asthma, right? So if we get this back and they're complaining of kind of this tightness in their throat and chest, some wheezing, yet they have no normal pulmonary function tests, we may need to consider vocal cord dysfunction, okay? Conversely, cool story, did you know that you can actually treat vocal cord dysfunction with laughing gas, actually, and nitrogen, because they're a lower molecular weight than oxygen. They actually pass through the vocal folds when closed. It's crazy, right? And it actually helps people, believe it or not. It helps. So it's nitrous oxide. So yeah, laughing gas. But all right, friends, the bronchial tree. Okay. Here we go. Okay, this is really, so obviously the lungs sit on the left and right side of the bronchial tree. So the trachea itself divides into the left and right primary bronchi and then branches off, right? Not only into, superior and inferior bronchi, but also lower down in the respiratory tree into bronchioles. Sorry, bronchioles. Okay, now, clearly at the end of the bronchiole is where the alveoli live. Okay, and this is where gas exchange occurs. You'll see when you look at this picture that there are various numbered lobes to the lungs. Okay, this is something that's actually obviously more relevant to people that might be going into respiratory therapy and or cardiac rehab. If you go to med school, you will definitely see this in a pulmonology clinic. Okay, so these are just different areas of the lungs. So here's the deal. All right, let's go back and look. Who can tell me, by the way, in this picture, all right, which lung is the left lung and what anatomical structure demarcates which one's left? Which one is the left lung and how do we know that anatomically? Okay, the chat. What saith the chat? Yes, Danielle. Nice job. Cardiac nose is on the left. Okay, sweet. Good. Okay, yes. Obviously, okay, so on the right, we have superior, middle, and inferior lobes. On the left, we just have a superior and inferior lobe. Okay, the cardiac notch obviously provides a resting place for the left ventricle and left atrium of the heart, atrium of the heart. Okay, so that's the anatomical structure. Okay, the alveolus, this is where the magic happens, okay, in the respiratory tract. This is where stuff gets real. Okay, so really, okay, we can see this little bronchiole, okay, branching out and opening up into these little tiny grape cluster looking things called alveoli. Okay, the point at which this bronchiole branches off into a cluster, okay, is called the alveolar duct. And you can see me pointing to an alveolar duct right here. Okay, that is the point where the bronchiole enters into the alveoli itself. Okay, now in the middle of this group in the middle of this alveoli, okay, is the alveolar sac. This is where the capillary bed lies. And then also as we look down here at this tiny little grape looking thing, little tiny ball, okay, that's the alveolus. Okay, and that's also where gas exchange occurs. So capillary bed exists here, and because because of the loose junctions that exist at the alveolus, we're able to have very simple transport of oxygen and O2 through the capillary bed at the alveolus, and that is how gas exchange occurs. Okay. Okay, friends, all the terms. As I said, there's a lot of terms here. Okay, so we're going to be covering things all the way from the top, from the nose, all the way down to the diaphragm. So, all right, here we go. Adenoido. First of all, who can tell me the adenoids and the tonsils share a similar characteristic? Does anybody know what characteristic that is? What are they? They're cousins. They just live in different areas. Okay, so both of these actually are lymphatic tissue. Okay, they're both lymphatic tissue. All right. Okay, so the adenoids actually live way superior, like at the throat, basically just distal to the ear, believe it or not. And everybody knows where the tonsils are. They're here. Okay, back of the throat. So crazy story. And for those of you that are going to go to med school, maybe you're going to be a PA and you end up working in your nose and throat. Maybe that's your specialty. That's what you go into. You're going to see kiddos, man. You're going to see kids with adenoids that are huge, so big. They have really enlarged adenoids. Okay, little story. So my my youngest brother, we were 16 years apart. Yeah, crazy. But my youngest brother, for the first 2 years of his life, was actually clinically deaf. He could not hear because, right, his adenoids were so large, they were so enlarged, they were actually obstructing his hearing. He couldn't hear, he couldn't talk, right, because his adenoids were like, so they were like huge, right? So we finally figured out what was going on, took him into to the ENT. They took his adenoids out. Immediately, he was able to hear us, and he started talking like within, I would say, weeks after that, right? Really crazy story. Okay, let's talk about the nose, okay? The anatomical root for the nose, naso or rhino, okay? Naso or rhino. Now, if I have, okay, and I do right now technically, if I have rhinorrhea, what do I have? Who can tell me? What is it?
A runny nose.
Oh, yes. Who was that? Sorry.
Was me.
Oh, okay.
Mary.
Sorry, which me? I can't.
Mary.
Okay, great, Mary. Thank you. Yeah, runny nose. You have a runny nose. Nice job. Okay, cool. All right. So then we have pharyngo. Okay, that is the root word for pharynx. Pharyngo. All right. If I have pharyngitis, I have an inflamed pharynx. Okay. Now here's the deal. We talk about lungs. There are like 6 different terms for the lung, if you can believe that. Okay. So we have lobo or pleuro, which means lung. Okay. Broncho or bronchus, which means broncho or bronchio, which means bronchus. Sorry. Pleuro, which means pleura. If you guys remember from the anatomy that you've had, the lung is actually covered by both a visceral pleura and a parietal pleura. So there's a visceral pleura, like almost kind of like a sheet of like cling wrap or like saran wrap that covers the outer surface of the lung. That's the visceral pleura. Okay, then we have the parietal pleura, which covers the chest wall itself. Okay, diaphragmato, diaphragm. Okay, and then we're back to lung. Okay, pneumo, pneumato, or pneumono. I don't know why they chose to have like 6 different words for lung is beyond me, but they do. Pulmono. Okay, pulmonologists are people who study lungs. Okay, septo, septum or wall. Okay, and then sinus or sinuso. Okay, sinus, yeah. Sorry, sinus or sino. I mean sinus. I think I put the S on there accidentally. Anyway, but here's the deal. Okay, question for you guys. If I have a pneumothorax, what does that mean? If I have a pneumothorax, what does that mean? Air in the chest. Okay, Mary, you're right. So that's when we have essentially an injury to the parietal pleura and or the visceral pleura of the lung, and air enters the chest wall. Okay, as a result of that, Mary, what happens? Mary or whoever, what happens because of that? What happens to the lung?
Collapsed lung.
It collapses. Yes, absolutely. Okay, very good. Okay, what about a hemothorax? What would a hemothorax be?
Blood in the chest.
Blood in the chest. Yeah. Sorry, which one of you guys was that?
It was me, Izzy.
Izzy, thank you. Yes. Yeah, it's blood in the chest. Good job. Okay, cool. All right. Okay, let's talk about some clinical terms, right, that we'll often see. Okay, clinical combining forms, typically describing pathologies. Okay, atalo, okay, means imperfect or incomplete. Okay, you're going to see a term here in just a few slides called atelectasis, which means imperfect or incomplete expansion of the lung or of the chest wall. Okay. Hemo or hemato, which means blood, as Izzy just said, blood in the chest, right? We have a hemothorax. Okay. Muco means mucus. Okay. Ortho, okay, means straight. So we can have orthopnea, which is breathing that is impacted by posture, right? Or breathing that is made worse actually by bending over, right? And better with standing up straight. Okay. Oxo or oxo. Okay. Oxygen. Okay. Root for oxygen. Pi or pio, pus, somno, sleep, unisom, right? The sleeping pill that they advertise on TV. Somno, okay, sleep. Spiro, okay, breath. Okay. If I have something that I'm using called a spirometer, what is that measuring? Spirometer, spirometry. Okay. So Noah, okay. Yes, Danielle, it measures breathing. Okay. Now here's the deal. Very often, particularly, and here's why I'm bringing this up. Okay, generally speaking, with patients that are bedridden, okay, or people that have prolonged immobilization, right, because of a surgery, maybe they have, you know, an intertrachea anterior femur fracture or some sort of like big trauma where they have to be non-weight bearing and they're in bed. Well, they can't necessarily get up and move around. So what are they at increased risk for after surgery?
Blood clots.
Okay, blood clots. Now, here's the deal. Okay, spirometry is often used in post-surgical settings, not only to track and keep an eye on essentially pulmonary output as a tool for checking for PE, pulmonary embolism, right? But also continued use of a spirometer, actually with the diaphragmatic contraction associated with that, and continued breathing, actually is a preventative measure for blood clots in people that are bedridden. So we tend to use that a lot in people that, quite frankly, cannot ambulate for one reason or another. All right. Thanks for hanging in there, guys. I know that this is uber fun, but we're going to keep on going. Okay. Prefixes. Okay. A or an. Okay. Without or absence. Okay. So someone who has sleep apnea. Okay, sleep apnea. What's the problem there? So we've already we know that the root P-N-E, okay, P-N-E-U is new, which means air, right? A-P. So apnea. What's the problem there? If they have sleep apnea, what's happening to them?
They're not breathing when they sleep.
Okay. Yep. All right. I wish I could see all of your faces at the same time. This is stressing me out. I can't see who's talking. Okay. Yeah. They're not breathing when they're sleeping. Okay. All right. Endo. Okay. Within. Okay. So if someone has, for example, endocarditis, okay, what do we think endocarditis would be?
Could that be like inflammation of the inside of the heart?
Yes. Yeah, absolutely. Yeah, amazing. Was that Matt? No, negative. Okay, sorry.
That was Egan.
Egan, dude, thanks. Sorry about that.
No problem.
Okay, cool. All right, you Okay, U is a prefix meaning normal, good, or true. Okay, we often in athletic training we use the term, you hydrated. Okay, they're truly hydrated because, yeah. Anyway, so U means normal or good. Okay, pan, all or total. Okay, if I have, for example, and I actually think I do, if I have pansinusitis, I have inflammation of how many of my sinuses?
All of them.
All of them. Yup, absolutely. Okay, cool. Poly obviously means many or much. Okay, so this is pretty self-explanatory. All right, suffixes. It just keeps on going. Okay, algia is pain. Okay, R or airy. Okay, pertaining to capnia. Okay, carbon dioxide. Synthesis. Okay, this means to aspirate fluid or take fluid out of. Okay, so for example, someone who has a hemothorax may undergo a thoracocentesis to drain the blood out of the thoracic cavity. Okay. Okay. EL. Okay. Pertaining to ectasis, expansion. So if you remember back a minute ago, we had a prefix called atelecto. But if I have atelectasis, what would that mean? So atelective, we remember, means incomplete. Okay. Atelectasis. What would that be? It's kind of a toughie, but atelectasis.
Like your lungs aren't expanding to their
Yeah. Yes. Yes. They're not expanding. I get super excited when people answer questions. If you can't tell, it literally makes my day. Yeah. I get uber excited. Yeah, the lungs aren't expanding. So we see this problem often in people with COPD, right? And people with pneumonia. Okay. They have atelectasis. They have a hard time with complete lung expansion, okay, and inspiration. Okay, cool. Emia, blood condition. Okay, gram, okay, is a suffix that means to record. Graphy, same thing, but it is the process of recording. So, okay. Meter, obviously self-explanatory, means measurement. Oxia, oxygen. If someone is hypoxic, if they are hypoxic, what would that mean? Hypoxic. Let me check that. Maybe there's something in the chat. Well, what do you know? Yeah, Mary, low oxygen. Okay, they are hypoxic. Okay, in my house this week, we've been using the living daylights out of a pulse oximeter to make sure that our O2 sats are up to snuff because no one wants to die. No one's dying in this house, I guarantee you. Not with me living here. Not letting that happen. Okay. All right, friends. Okay, PEXI, surgical fixation. We'll talk about that actually when we get to the urology section, as well as the reproductive section. We're going to talk about that stuff specifically. Okay, apnea, pneumo. Okay, breathing. Okay, we know about RIA. Okay, RIA. Okay, but what about ragia, hemorrhagia? Okay, it's not when something is angry. Okay, it's when there is rapid blood flow, hemorrhagia. Okay, raging river flowing very fast. Okay, hemorrhagia. Okay, rapid blood flow, spurting artery, rapid blood loss. Okay. All right, I got to move my thing to see the last one. Stomy. Okay, it's just creation of an opening. Okay, so. Okay. My last question. I do this a lot, guys. I do like little quiz questions as we go through this. Okay. But if if I did a thoracostomy on someone, what would that be? Thoracostomy.
You're opening the chest.
Yeah, you're cutting an opening into the chest. A thoracostomy. Okay, into the chest wall. Nice. Okay, we have to do that before we put in a chest tube. Okay. All right, friends. Some words to know. Okay, we've already kind of talked about. Whoa. Okay. All right, here we go. So we've talked about some of these. Okay, bronchitis. Okay, we know what that means. Inflammation of the bronchi. Atelectasis, we talked about that one. Okay, incomplete expansion of the lungs. Okay, bronchiectasis. Okay, bronchiectasis means expansion or widening of the bronchus. Okay, here's a tongue twister. Bronchogenic carcinoma. What would that be? And I know we haven't kind of covered that one in detail yet, but bronchogenic carcinoma. Let's see. Let's break it down. Broncho. Okay, so there's one, broncho. So we already know pertaining to the bronchus. Genic. Okay, genic, genesis, right? It originated, genic, it originated in the bronchus. I see some like slight head nodding, right? Okay, and anytime we see the term carcinoma, what does that mean? Nothing? Okay, cancer. So that is a cancer that originates in the bronchus, okay? We talked about pneumothorax, okay, laryngitis, lobar pneumonia, okay? This is pneumonia that is confined to only one lobe of the lung, okay? Pansinusitis, which is what I have today, okay? Pharyngitis, okay? This is essentially sore throat, okay? Pleuritis, inflammation of the pleura, okay? Pneumonitis, okay? Inflammation of the lungs. Rhinitis, need I say more? Rhinorrhagia, okay? All right, and tonsillitis. Okay, friends. Coding of respiratory conditions rises from groups J00 through J99. Yay, fun. Okay. All right, guys, that is, wow, we're done 22 minutes early. Okay, let's go through some questions. Does anybody have any questions about anything we just covered today? I know we flew through a lot of information really fast because J-term, but what questions can I answer? None? Wow. Well, cool. All right, guys. Well, I hope that obviously Tuesday, my plan, unless things go south, I hope that that shouldn't happen, but my plan is to be on campus on Tuesday. We'll meet in Nobel 3302, okay, at 1:30, and it's going to be a whale of a time. Okay, we'll talk about terms. We'll draw some stuff on the board, maybe get up and do some stuff, okay? I feel like, yeah, I feel like J-term. You guys just look, some of you guys just look like you're just not having J-term. And we're like 2 days in, but okay. If there are no questions, I will post a quiz that'll be up here very shortly. And that's everything for the week, okay? Everything for the week, everything that you need. So don't forget, okay, you got your quizzes. You got the discussion, you have, and then you just have, yeah, that's it. Quizzes and discussion, that's it. Are there any questions about the class that I can answer? And that actually reminds me of something, but I'll let you guys answer that before I go to my next step. No. Okay. Hey, so the one thing that I thought about, I was going to mention this at the beginning of class, but all of you guys saw my announcement. So I got like multiple emails about like the first question on the quiz. And anytime there's a short answer question, guys, I always go back in and regrade those manually. I always do that because I know that it is nearly impossible for you guys to guess, you know, a word combination that I put into a blank for an answer because I know that that's reality. I always go back in and check those. Okay. So please don't forget about that. If those things pop up, know that those things will always be manually graded by me. Okay. I will not leave Moodle to its devices on those types of questions. Okay. Nothing else. All right. You guys have a great rest of the week. Okay. Man, that was fast. What do you say? Peace out. I'm gone. That was super fast. But if you need anything, please let me know. I know it's the first time that we've met together. You guys don't know me very well yet. But one thing that I'm serious about is making myself available for my students and helping where needed. So if you need help, please ask me. And I promise I will do everything that I can to help. Okay. So at that, I'll let you guys go, but have a wonderful rest of your Thursday. Okay. And I'll talk to you guys next week. Okay.
Thank you.
Yeah, you're welcome,
Thank
guys.
you.
Take
Thank
care.
you.
Thank you.
Yeah, of course.
This is completely off topic, but I know you have COVID and I just like recovered from it. And
Yeah.
I was gonna suggest, I don't know if you have kids or not, but what really helped me, I really was stuffed. Like I couldn't breathe out my nose and like
Yeah.
it was just a horrible feeling. But getting like that Vicks Vapo and putting it in your bathtub
Yeah.
and then like letting the hot water run and like
Yeah.
letting the sink run and just like locking yourself in the bathroom really does wonders. Like I got out of the bathroom and I felt like I was not even sick at all. Like I could just breathe normally. So I was just gonna like suggest that, knowing that you're like you have COVID now.
Cooley, you're totally right. Like, actually, one of the first things I did, actually before I tested positive, was I went and bought like one of those like humidifiers, and I filled it up
Yeah.
with like hot water, and I literally put that in my room when I sleep at night, and I leave it on, and it helps like amazingly. Although the one thing that I would want to do is go like get a nebulizer and fill it with warm saline and just like, yeah. But no, you're absolutely correct. And thank you so much. That's like ridiculously kind of you. So I really
No,
appreciate
That's not why I stayed on, but I had COVID earlier this year in February, and my humidifier also saved my life. So,
Yeah. But really though, right?
yes,
It's amazing.
so nice.
Kool-Aid, thank you. That's really, really nice of you.
no problem. See you next week.
All right, I'll see you next week.
Bye.
Bye.
Hi, I just had a really quick question about the question number 2 on the quiz. I'm not trying to be like nitpicky or anything. Okay, so SARS stands for sudden acute respiratory syndrome, right?
Yes.
Okay, so what I was confused about is it says like it's a term that's formed by combining multiple word parts.
Yeah. Yep.
So, but isn't it multiple words?
Hang on one second. Oh, you know what, Emma, I'm so sorry. Actually, here's the deal. So I actually had this, I had this question from somebody else last night, and so, or yesterday rather. And so, yes, so here's what happened there. Okay. That was my mistake. I was writing that question when I was ridiculously hopped up on Mucinex and Tylenol.
It's all good.
And no, so that was my fault. You reminded me of that. But yes, I answered that question from someone else, and that was my error when I was writing the question.
Okay,
I was
sounds
going
good.
too
I just wanted to
fast.
make sure I wasn't like misunderstanding something.
No, Emma, that was me. I was like,
Okay.
like flying crazy fast through the
No, I
classrooms.
can't imagine.
I made
I have so much respect for you teaching like 4 hours a day with COVID, so I can't imagine.
No, that was my fault. But no, but thank you for asking though. I will,
Yeah.
I'll correct it. Okay.
Okay, I'm not worried about it, but thank you so much. All right, I hope you feel better. I'll see you
All right.
next week.
I'll see you Tuesday.
Bye.
Bye. I need a title.